This is an interview with D.A. Henderson on July 12, 2008 at the Centers for Disease Control and Prevention in Atlanta, Georgia, about his involvement with the Smallpox Eradication Program. The interview is being conducted as a part of a reunion marking the 40th anniversary of the program in Asia and East Africa. The interviewer is Paul O'Grady. Can you state your name?
D.A. Henderson.
And you understand that this oral history is being recorded?
Yes, I do.
Thank you. I'd like to start off by having you give us a little bit about your background, what led you to a career in public health, and how you started working for the CDC.
Well, I was born and brought up in Lakewood, Ohio, near Cleveland. Went to Oberlin College and then to the University of Rochester School of Medicine. And after internship at the Mary Imogene Bassett Hospital in Cooperstown, I was told that my deferment from the draft was at an end. And I had my choice either to voluntarily enlist, in which case I would be a first lieutenant, or be drafted, in which case I'd be a private. So like many of my colleagues who'd been deferred since, in my case, 1946, and this was 1955, I decided I would volunteer. I was having difficulty making up my mind whether it was Army, Navy, or Air Force, and I figured I'm just an intern. All I'm going to do are boring draft physicals, physicals of new recruits. So about this time, somebody shows up from something called the Communicable Disease Center, which I'd never heard of, and they from the Public Health Service, which I knew nothing about. But they talked about working on infectious diseases, which I didn't really much care for. But as I thought about it, well, it might be 2 years and I'd learned something. And as they pointed out, we don't wear uniforms, we don't salute, you don't do basic training. And I thought, well, okay, doesn't sound too bad. So I enlisted in the Public Health Service. Now, this was the Epidemic Intelligence Service, which at that time was only 4 years old. They're created by Alex Langmuir at the CDC. And there were, however, quite a number of applicants every year who were anxious to do their required time in service at CDC. It would be challenging, interesting, so forth. Well, fortunately, I had done a history of medicine paper in my last year of medical school. Why had I done a history of medicine paper? Because they offered $200. And a handy subject was something about cholera in upstate New York in 1834. And there was material available in the newspapers and so forth. And so I spent time creating this paper, going through the newspapers, plotting cases, doing curves. I didn't know what I was doing in terms of training, but it really was epidemiology. And in fact, it turned out to be rather fun to see what the responses of the health department were to the various challenges, seeing how it spread through the city and so forth. So inadvertently, I'd become interested in a subject which we'd had no courses in at all. And I got drafted to the Public Health Service. That's where I got into public health, and I had no interest in public health either at that time. I was going to be, in my mind, a cardiologist, and this would be 2 years out, and then I go back to my residency in cardiology.
What were the major public health concerns at that time?
There was one dominant major public health problem at that time, or challenge, and that was poliomyelitis. There had been significant cases, significant outbreaks of poliomyelitis in the 1950s. There was a great deal of fear at that time about polio. In the summers, they closed swimming pools. Parents kept their children away from other children. if there were outbreaks, there was a great deal of anxiety in the community. The National Foundation for Infantile Paralysis was a very major foundation. It was the only categorical disease foundation at all at that time. It had been started because of President Roosevelt's, Franklin D. Roosevelt's poliomyelitis, and they'd raised money for Warm Springs, Georgia Rehabilitation Center. They'd been extremely successful. And they took some of this money and they put it into some basic research of very good quality and development of a vaccine. And there was great anticipation in 1954 because they began the first major study of the Salk vaccine. And it was school children across the country. I forget how many were involved. As I recall, it's 100,000 plus. And the results were coming up in April of that year that I was doing my internship. And very soon thereafter, they began to, in April, I guess they announced the results, and they began a vaccination around the country with the vaccine. About this time, they found that some of the lots of vaccine were not quite, the virus was not quite as dead as it should be. And they began to get cases of poliomyelitis, paralytic disease, caused by the vaccine. So I was being inducted into Centers for Disease Control. The Epidemic Intelligence Service, Alex Langmuir's group, were doing the work of compiling information on the cases and trying to find out which lots of vaccine were involved and trying to determine the magnitude of the problem and then what to do about it. So we were totally immersed as I came into the service on the 1st of July with what was an ongoing investigation into what really was the end of the largest field trial ever conducted on a vaccine, and the introduction of the poliomyelitis vaccine, which had been awaited for so long, and at the same time we had what was amounted to a vaccine incident, which was serious, with a number of paralytic cases associated with the vaccine. And the question was it the vaccine of all companies, or was it maybe one company and only some lots of the vaccine, or what was it? And so this was all absorbing for many of those who came aboard at that time.
And how many years were you at CDC after so you had a 2-year government required service, and then you stayed on?
Well, it turned out to be rather more exciting than I had thought. They had a matching program, so that of those who were recruited, you then submitted your preferences on a list of different positions you could have. And they, in turn, would look at the people who were coming in, about 30, 35 of us, and decide which ones they wanted, and they would list their priorities, and then they matched them up. And I matched up with a position which was called Assistant Chief of the Epidemic Intelligence Service, which would be, as they called it, a gopher job, kind of putting things together, helping organize a course, and doing things of this sort. Well, we had a course a 1 month at that time, where they taught us epidemiology and biostatistics, basically how to investigate an outbreak. And at the end of the 1 month, you were then a qualified epidemiologist in our terms. And at the end of that course, I had to go off, as the Epidemic Intelligence Service did, to an epidemic. We were constantly being called for various epidemics. There's a big epidemic of diphtheria in Phoenix City, Alabama. And I went down. I spent 3 weeks down there and giving vaccine, taking cultures. The patients were housed in a big Red Cross tent. I came back, And here was the Chief Epidemic Intelligence Service officer packing his bags. And I said, "Where are you going?" He said, "I have another job. I'm going to be a state health commissioner." And I said, "Well, what do I do?" He said, "I guess you're the Chief EIS officer." I said, "I have no idea what to do." He said, "You'll learn." And sure enough, then I began working in a job which I certainly was not qualified for, but plunged in, and with the mentorship of this Alex Langmuir, who was a legendary epidemiologist, a rather difficult person, but demanding, and just a wonderful teacher, just an extraordinary teacher. And at the end of 2 years of this, I'd finished my duty. I proposed to him, you know, we're not keeping many people on. The people we're getting, so many people apply. They're well qualified. All of them want to do academic medicine or pediatrics, just about. Nobody wants public health. But now, if we offered a 5-year training program in which you do 2 years of training, like a residency in cardiology, as I was thinking for myself, and maybe then 3 years with a public health service, maybe that would be a way to attract people. Then by then you will have stayed in 7 years, and we might get people staying longer. Well, he liked the idea, and we submitted it up the line to the Surgeon General. He liked the idea, so I applied for a 5-year training program. And went back to get my residency. At the end of the, well, during the course of the residency, I found this to be, frankly, rather boring. I was seeing patients, and some of them had some heart disease, heart failure, a little diabetes, a little gastroenteritis, a little constipation. And sort of at the end of the day, I felt, you know, if I really hadn't been there, I wonder if it would have made any difference. And was I making any difference? Am I going to be doing this for my next 40 years? Well, meanwhile, I'd been 2 years in the Epidemic Intelligence Service with some exciting outbreaks here and there, including one which was an interesting one in Argentina. There's a big outbreak of foodborne disease. They were stoning the restaurant. The Argentine government was upset. They thought it was a type of food poisoning due to botulinum toxin. They wanted what we had in the way of antitoxin to treat them, so I took off for Argentina with such supplies as we had.
And when was this?
It was 1957. And at the end of this, I saw the Secretary of Health, and he sort of offered, well, let's go on a hunting trip or a shooting trip with me at my lodge. And I said, you know, I hear you've got an outbreak of smallpox. And he said, yes. And I said, I'd like to go see it. So he said, fine. And so we took off on an old Pan Am clipper off the waters in the river, La Plata, on up to another place, and we got in a small 2-passenger Piper Cub and flew into smallpox, the area where they had the smallpox, and they had an outbreak of smallpox. And the people were in tents in the field, and so about 30 different patients. We looked at the patients one by one. It was fascinating. And at that point, I'd never seen a case of smallpox, really didn't know what it looked like. But it was my first contact with smallpox.
Was there, at that point, any national or international interest in trying to organize the fight for smallpox?
The international concerns about smallpox were there very, very strongly because all travelers were obliged to carry certificates indicating they'd been successfully vaccinated within the preceding 3 years. And just about every country, including our own, enforced this. And if you weren't vaccinated, you wouldn't get admitted, or they might vaccinate you on the spot. There was a great concern about importations of smallpox. And it was in 1958 just about a year later, after I'd seen the cases, that the Vice Minister of the Soviet Union proposed to the World Health Assembly that they undertake a program to eradicate smallpox. That was the year the Soviets came back into the UN family of nations. They'd withdrawn because of the Korean War, and they just come back. So the proposal, they looked at this, the delegates at the assembly looked at this, and they really wanted to be helpful and encourage the Soviets at this time. And so a year later, they approved a program to eradicate smallpox. The only thing was that at that time, the World Health Organization was deeply involved in a program to eradicate malaria. And fully a third of all the staff were involved in that. And all the spare money they could get together, because it was very expensive, very costly. And the idea of undertaking another eradication program was really not the intent of the Director General. In fact, the only thing he could do is say fine, and he really gave it very little money, and a few countries then did some vaccinating and tried to get rid of smallpox, and they did make some progress on this, but it basically was not going anywhere. But that was the beginning, was 1959, when they decided that they would undertake a global program, but it really was not anything that was happening. It was, seriously, it was not until 1966 that they really took it seriously.
What was the attitude of the United States government towards this program that seemed to have gotten some impetus from the Soviet Union? Was there any political peculiarities about that?
There clearly was an element of Cold War competition. The U.S. was heavily supporting the malaria eradication program, both through the organization, very heavily, and through direct bilateral donations to the countries. So the U.S., you could almost say, owned the malaria eradication program. The Russians had no program at that point that they could say the same thing about. So in a way, they came in with the smallpox and said, look, we got rid of it in the Soviet Union back in the 1930s when our vaccine wasn't so good, when health conditions were poor, where personnel were not well trained, and we got rid of it. So why can't the rest of the world get rid of it? And so that's where they came in. And then, but after 1959, every year at the World Health Assembly, they would really give the Director General a very hard time. Why aren't you putting more money into the smallpox program? Why do you favor the malaria program? And so that went on as a continuing piece. The U.S. really took no notice of it, is really what it amounted to. Until really it came up to 1965 when a change came for the U.S.
Which was?
Well, in 1965, I'll go back a little bit, 1961, Merck Sharp and Dohme at that time was introducing a new measles vaccine. And it caused a lot of fever in children. And so in the U.S., they were using it, giving the measles vaccine, and they gave them some immune globulin at the same time so that they wouldn't have so many reactions to the measles vaccine illness, if you will. This made little practical sense if you went to Africa. The idea of doing these two together made life a lot more complicated. You really could not do large-scale vaccination and try to preserve the immune globulin and deal with two shots to get this. So they undertook studies in Upper Volta, Benin. Upper Volta is the place where they were doing the country. They did X number of children, 150, 200. They kids reacted very well, no complications. Then they asked the country minister, said, could you do it for all kids under 6 years of age? And so they gave them a vaccine enough for that. And then there was an organization, French organization, that had a number of countries, and he said, could we do it for 6 countries now? And USAID said, okay, we'll do it for 6 countries. Well, things didn't go very well with 6. And I won't go into all of the complications, but we got drawn in at that point to evaluating it. And I sent one person over to evaluate. It was a disaster. Well, not to be deterred, they decided we're now going to do 11 countries. And we need from you 11 people for 6 months each to help get the program started in each country. And I thought, we can't do that. Really, it's a good segment of my staff. And sending people over for 6 months at a stretch is without families and what have you. This is tough. So I thought, you know, I really have to work with AID. We've really got to be responsive to them. And I didn't know what to do. So I decided, all right, let's put together a proposal that we would say is sound from this public health standpoint. Why was the measles proposal bad? Well, they were going to give it for just 4 years and then stop. In other words, AID would support it for 4 years, and they expected the countries to continue. It cost $1.75 a dose, and the countries couldn't afford 10 cents a dose for yellow fever vaccine. Well, this is not good public health practice to start a program, get the hopes of the public up, and then drop it. This is a terrible way to do it. Smallpox vaccine, however, cost a penny a dose. So we proposed the idea, well, suppose you take this whole block of countries, 18 countries, and suppose you do smallpox vaccination.
And you're talking about West Africa?
This is all West and Central Africa, as we called it. And so we do 18 countries. You give smallpox and develop a smallpox program there. We could get rid of smallpox in that whole area. They could then would have an established program for vaccination, and they could continue it easily when it only cost them $0.01 a dose in vaccinating newborns and so forth. And then if they want to have measles vaccine added and the ministers think this is a good idea, we would be happy to give measles vaccine at the same time. But we can't eradicate it because measles spreads too easily. We couldn't get rid of it. But at least the countries would have to think through, was this a good idea to do this with measles vaccine as well? Well, I think the cost that what USAID expected to spend was about $5 or $6 million. The proposal we submitted was about $35 million. So I knew it was going to be turned down. But on the other hand, I thought it was going to be a point of departure for discussion. And I didn't know where we were going to find any sort of compromise on this. Their demands were so great that it was impossible. So I set it up through channels to the Surgeon General. And very shortly, USAID turned it down. And we were just debating along about autumn what we would do subsequently on this.
And we're still in 1965?
This is 1965, when all of a sudden we got information that the president had decided to approve the program, the whole program. And this shook everybody. My boss, Alex Langmuir, was absolutely beside himself. As I told him, they were not supposed to accept it. But the president was looking for an initiative which would be something that he could publicize, that the U.S. was contributing to a UN international cooperation year. And there were several proposals that went forward, and this, I had no idea was even being considered. And suddenly AID was told by the White House, fund it. And all of a sudden, we're told, all of a sudden, we've got 18 programs to set up in West and Central Africa. We had never run a program outside the United States at all.
So you must have been faced with a tremendous manpower problem.
Well, we would need about 54 people that we were going to have to recruit. AID said that it probably would be, you can't do this under 3 years. They agreed finally to fund it then in November. They felt we could get it in 3 years. I said, no, this is wrong. It's just going to too much of a delay. How about 13 months? So we'll have the people over there in January of 1967. They thought it was almost impossible. You've got individual agreements with every country. You've got to order the vaccine. You've got to put on training programs. You've got to recruit all the people. We did. Recruited the people. We got the vaccine ordered. We got vehicles. We had to use U.S. American vehicles. There weren't any in all of these countries. No maintenance, no repair, so we had to set up workshops and everything else to train our people to be mechanics. We had to lay out plans for all of the countries, get everything signed, and we did.
Let's talk just for a second about the attitudes of the countries involved. What was the interactions with the governments like?
Well, in November, as soon as this was approved, I went over with a consultant that I had who was Warren Winkelstein, who was a good epidemiologist and spoke French, and another person by the name of Dr. Henry Gelfand. The three of us went and visited each of the different countries. Fortunately, a number of them were having a meeting so we could present it to all of them at one time. They're enthusiastic. Why were they enthusiastic? Most of them, more because of the measles vaccine. Because this is in Africa, this is a very deadly disease. It's 10–15% death rate. The French-speaking countries, by and large, had done some pretty good vaccination with pretty good vaccine. The English-speaking countries had a lot of smallpox. They were more enthusiastic about the smallpox. But they were getting both, and they were really very enthusiastic. We were coming up with vehicles, we were coming up with vaccines, and consultant help, but not a lot of people. It was by and large 1 or 2 people or advisors to be assigned to most of the countries, with a few more in Nigeria.
And how about the Americans that were going to go over there as part of this program? Talk a little bit about their attitude.
Well, the Americans who were going over there, a number of the people, some of them I had known and basically called up and said, we've got this coming up, are you free or would you be interested? People, contemporaries and so forth. I had a couple of people who were already serving in CDC and took them. And basically it was almost word-of-mouth advertising because there just wasn't very much time, and contacts with people at schools of medicine and other places, infectious disease people that might know of people interested in this. And people, the word of mouth, by word of mouth, they learned about this, and my goodness, we were able to recruit enough so that we were able to begin the training program in July of 1966.
And people were on the ground?
Well, they had to finish up the training, we had to get all the agreements signed, and I think we got all of them into 16 of the 18 countries. We managed to postpone 2, but we had 16 of them by January of 1967. But meanwhile, there was a little problem. There was a debate coming up in the Assembly in May of 1966, so this is only like about 6–7 months after this approval for the whole West African program had come through.
Debate in the United Nations Assembly?
Debated in the World Health Assembly.
Okay.
Every year, the ministers of health convene in May, in Geneva to look at issues of health. And so they're debating the question of going with an intensified program of smallpox eradication with a budget of $2.4 million a year and an objective to complete that within 10 years. The Director General, Marcelino Candão, a very capable Brazilian, knew that it was impossible to eradicate it. He felt you had to vaccinate everybody in the world, and he was a Brazilian, and he knew that there were tribes in the Amazon that hadn't been found, or were just recently found, or that sort of thing. So he knew it couldn't be done. There were a number of countries that were very doubtful of the concept of eradication at all because they were having so much trouble with malaria eradication. And there are others who thought this was far too ambitious for an organization like WHO, which was not, except for the malaria, really hadn't run programs or really coordinated that way operationally health programs. So it came to the debate in the Assembly. The U.S. had, as I said, been very quiet before this, really in taking a position. But at this Assembly, they were going to take a vote finally, because it was very controversial whether they went ahead or didn't go ahead. One of the strong arguments was, well, the U.S. has already committed funds and personnel to take care of 18 countries. So that's a big start on this whole thing. And after 2 or 3 days debate, they did vote. They had to have 58 votes to start the program. And it passed by just 2 votes. It was the closest vote they've ever had in the World Health Assembly. The Director General was furious and felt that the Assembly had committed the World Health Organization to a program which was going to fail, and it would bring the organization into disrepute and question the credibility of public health and the World Health Organization. And he blamed the U.S. for this. Well, in a way, it was true. If the U.S. had not done this crazy thing in West and Central Africa, that almost certainly the voting would not have gone as it did. So he was blaming the U.S., and he then called the Surgeon General in the U.S. and said, I want an American to run the program, because when it goes down, when it fails, I want it to be seen that there's an American there and the U.S. is really responsible for this dreadful thing that you've launched the World Health Organization into. And the person I want is Henderson. Well, I was associated, of course, with the West African program, of having gotten involved and starting it and so forth. And so I got called to Washington, and I was told I was being reassigned to be head of the World Health Organization's global smallpox program. And I declined. I said, we're just starting this West African program. It's a huge amount of work. And we just barely started. The $2.4 million, we've got to go work programs in 50 countries. We don't even have enough money. $2.4 million won't even buy the vaccine we need. And I'd had some experience in working with the World Health Organization, and they really were not working well together. Each of the 6 regional offices was sort of wholly independent, and trying to coordinate them was a terrible job. So I said, I really can't do it. I think this is a very difficult task, and I think if we do a good job in West Africa, we're going to show what can be done. And maybe that will encourage the other countries, but that's, I think, where I ought to stay.
Was this conversation going on between you and the Surgeon General?
Yes. And so I declined, and he said, I said, we don't order people in the public health service to go from place to place. We talk about career opportunities and so forth and so on. It's not like the military services. And he said, well, this is your career opportunity. And I said, and suppose I decline? He said, you're fired. And I said, you're serious? And he said, I'm very serious. I'll tell you what, make a deal. You go for 18 months. And if at any time during that 18 months you really feel it won't go, just send me a telegram, just put now, and I'll pull you out. So I headed for Geneva to head up the global program. We left in October to go to Geneva, get a house, wife and 3 kids. Left half of our household goods in storage because we knew he'd be back pretty soon. And took over a program, which is a global program. And this provided for headquarters staff, eventually of 9 of us. It never got bigger than that. So there were 5 medical officers, 2 admin officers, and a couple of secretaries. That was our total staff.
Let me ask you about your own mindset at this point. You'd mentioned the problems with the measles program and that malaria eradication had been problematic. Were you optimistic at this point about, at least with respect to the West African piece of the puzzle, were you optimistic about eradication's success?
It's a good question as to whether you would characterize what I felt as optimistic. It was, my feeling was it was doable, but without a full appreciation of everything, all the problems we would encounter. And I must say, as I thought back on it, had I any idea of all the problems that we'd face, I would have not been optimistic. You can't anticipate civil wars, floods, masses of refugees, one thing after another, and bureaucratic blockage of things, countries refusing to participate, all of the difficulties you can have with this. But fortunately, I was innocent of the problems, these problems that you would encounter, or we couldn't anticipate, obviously, most of these. And it was the fact we had a good vaccine, and the vaccine we knew, and we'd done some studies at CDC while I was in charge of the surveillance program, showing the vaccine was very good, and you could get virtually 100% takes using a proper technique. And we had jet injectors that we'd worked with and perfected these with the inventor and the U.S. Army so that we could have jet injectors that could vaccinate 1,000 people an hour. And they looked very optimistic that we could do a lot of vaccination with them. So that we had a good vaccine. You knew something about smallpox. You know that we knew that there were a number of countries, developing countries, who didn't seem to have any cases, but the reporting was so bad that little did we know that many of them just weren't reporting it. But you really didn't have an idea, but we thought there were large countries free of the disease. Certainly the U.S. was, and Canada was, and certainly there must be others that were involved too. So it was a feeling of, technically this was doable, but without an appreciation that experience would provide as to just how difficult the problem would be.
All right, well, let's take me back to Geneva. You've arrived, you have your family there, and when did you start to realize that these challenges were going to present themselves?
Well, we quickly found that we had problems. Within just the first couple of years, we ran into a number of problems.
Can you?
The West African program, basically, Don Millar, who took over for me, who'd been my chief of my smallpox unit before, he was running it, and he had a good administrative officer, and he had some very good people in the field. And my feeling was that they had to run that themselves, and the only thing we could help them with, which they needed, was some local costs. And I think we gave them a couple of $100,000 a year to permit, in some countries, purchase of gasoline and a few other things. They couldn't get it legally with their U.S. aid funds. But other than that, they were on their own. So we looked at the world and saw, well, we got two countries sitting rather at the far end. One is Indonesia. The other is Brazil. Now, at that time, South America appeared to be free of smallpox except for Brazil. They'd done vaccination programs in the other countries, and one way or another, with their infrastructure, not perfect, but they'd managed to get rid of smallpox. That, of course, was encouraging. But if we got rid of it in Brazil, then they would be far away from endemic areas, and indeed they could be basically the funds that we were putting into a Brazilian program could be withdrawn, and we put it in other areas like Asia or Africa. And similar with Indonesia, Indonesia is sitting off way over here, and the countries nearby are free of smallpox. So the chances of smallpox being imported into Indonesia, if we got that free, would be small, and therefore the limited amount of funds we could we could then transfer that to other countries and at least make a start in trying to get rid of the smallpox with the limited funds we had. So that was the strategy. We almost immediately found we had a vaccine problem. The Russians had pledged 25 million doses a year, and we had no idea of how much vaccine we'd really need. Most of the countries were doing some vaccination. The disease was so severe, it was such a problem that at least they had to vaccinate in the big cities, simply because of civil disorder. With too much of this epidemic smallpox, it is destabilizing. So all countries were doing some vaccination, and what we made the assumption that most of them already have vaccine, and we've got 25 million from the Soviet Union. The U.S. is covering all the vaccine needs in their 18 countries, later 20 countries. And so we ought to be all right. But I thought we need to have some way to determine whether the vaccine is really potent, really good. So I went to the Netherlands and asked if they would help in doing testing the vaccine quality of the production that was there. And then we went to Connaught Laboratories in Canada, and they agreed to do that as well. So we began getting samples of vaccine from the different countries, and they began testing it. 5% of it was potent and stable. 5% met international standards. So we had a problem almost immediately. We couldn't afford to buy the vaccine. So I made a decision. We won't buy any vaccine. We're going to have to improve the vaccine production facilities that are out there. So we called a meeting of the vaccine producers from several major laboratories. From Wyeth Laboratories in the U.S., they were the producer here. They had one Lister Institute in London. We had Netherlands were there. Soviet Union were there. I think that was it. And we brought them together, and we talked about vaccination and developing a standard manual. Because every country was using, where they were making the vaccine, they were using all sorts of different techniques. So let's get what we think is the best way to do it in a simple manual that I can understand. And then let us then help these countries improve their vaccine. We will then work with UNICEF to try to get them to provide some machines so that they could freeze-dry the vaccine. And we would use some of the people from the consultant laboratories that we had brought together to go out and train and help develop the vaccines. And that's what we did. And the vaccine quality began to pick up. And it was by about 1972, we had more than 80% of the vaccine was being produced in the endemic countries themselves. And it was good quality. So we were immediately involved in trying to solve just the vaccine problem. How to administer the vaccine was the second problem. And the problem was this. You have a vaccine which is has a vial, it's in a vial with about 0.25 milliliters of fluid that is reconstituted. You have one vial that has dried powder of the vaccine, another which has 1/4 of a milliliter of fluid, which is a very small amount. To use the vaccine, you have to put the liquid into the dry powder, mix it up. And then you have to put it on the arm. And the way they did this in most of the developing countries was take like a glass rod, dip it in, and then put it on dip the rod against the arm, tip it against the arm, and a little drop would be there. And then, by and large, what they did was scratch through the vaccine, made a number of scratches through the vaccine. It's an old technique which goes back more than 100 years. In the U.S., we did it a little bit differently, but it was the same principle. But it was important that the U.S. did it this way. They took a needle, they put the drop on the back on the arm, and then they gently pushed the virus through the skin. And the idea was that if you get it just through the skin, it'll grow and produce something. If you push too hard, you get bleeding. If the bleeding occurs, then it washes out the virus. If you don't push hard enough, it doesn't go into the skin, and so the vaccination fails. Wyeth Laboratories was developing a new device, which I visited Wyeth Laboratories because it was the question of improving our vaccine production capabilities in the other countries. And they showed me this wonderful device which they developed, a little needle about, so long, and had 2 little prongs on the end. And they called it a bifurcated or sort of 2-forked needle. The idea was you put the needle into the vaccine and you just withdrew it. And between those 2 prongs, a little bit of vaccine would be held. And then they thought you press it through the skin. And this way, the amount of vaccine you could get from a vial was 100 doses rather than 25 doses. Well, I looked at it, and I know how much trouble we'd had in trying to teach medical students how to vaccinate, because they were forever not getting it quite, not enough pressure to break the skin, so it wasn't growing. And then a number of them were getting a little bit of drop of blood, and that was thought to be bad. So I raised the question of, well, suppose that we take a needle and just hold it like this and poke it like this. We called it multiple puncture. Instead of scratching or pressing it through, we do multiple puncture. We're going to get bleeding. So let's see what happens. So we tried a few of these. They all got very successful takes. We took it to the field into Kenya and Egypt and did several hundred children, and we did it very vigorously so that there was a little drop of blood on every one. Every single one of them was successful. So this was incredible. All of a sudden, we're going to have 4 times as much vaccine than we thought we had or were getting with these wonderful needles. The needles cost us, we shortened them up a little bit to make them cheaper. Then we made them out of a stainless steel virtually, so that we could get 1,000 of them for $5. You could boil them and reuse them, and we ran through about 120 vaccinations, perfectly good. So we had needles very inexpensively. We had a vaccine, and suddenly we had 4 times as much vaccine as we thought we had. And then it was a matter of then bringing those into play in the different countries. And this went very rapidly. So it was another development right at the beginning which made a huge difference. It was a crazy little thing. Now the important thing I think is that the inventor of this, a man by the name of Ben Rubin, received at one time what's called the John Scott Medal of the City of Philadelphia for the best or most important invention of a particular year. And here he was getting this, and it had gone back, the award goes back to the 1700s. Marconi's received it, Edison has received it, and so forth. And he said, this is the most insignificant patent or invention I've ever made. And he said, and here I am receiving the John Scott Medal. And it just was it was like inventing the safety pin. It was so incredible. So we began using that. We had introduced the jet injectors for West Africa, but very soon we said, for this price, we don't have problems with mechanics or repair or what have you. It's very inexpensive, much less expensive than a jet injector. So pretty soon the bifurcated needles took over the whole of the world in terms of vaccination. Well, these were a couple of the very early problems that we had. There were many more.
So tell me how the smallpox program moved into Asia and East Africa.
Well, West Africa, let me go back to the West African program, which began in '67, and they managed to record their last case in 1971. Well ahead of schedule and under budget. Not too many programs come through like that. Meanwhile, I had a man in East Africa, and he was working with the people in the different countries and helping them and strengthening what they were doing, a Russian, Ivan Ladny. And they began to make very good progress. We, from WHO, began supporting Central Africa, not Central Africa, but Sudan and Zaire, 2 huge countries across the middle. And these were frightfully difficult, but we had some very good people, incredible people, some nationals, some internationals, and they began to make a good deal of progress. Brazil, I go back to say Brazil became free in '71. We had Indonesia was a bit of a struggle, but they became free by 1972. And in fact, the whole of Africa was free of smallpox, except for Ethiopia. The whole of Africa was free of smallpox by the summer of 1973. So we were only 6 years into the program. And here we were with a good piece of the world free now of smallpox. So in the summer of 1973, we were down to just 5 countries that had smallpox, just 5. It was India, Pakistan, Nepal, Bangladesh in Asia, and Ethiopia. But when you looked at India and that group, that bunch of countries, I think the population then was maybe about 700 million. So you look at it and you say only 4 countries in Asia, but 700 million people is at that time almost 3 times the size of the United States. So it was not a small undertaking to do with that. Meanwhile, in Ethiopia, they were doing a malaria program, and they did not want to see a smallpox program. So the Minister of Health refused to even have me go and talk with him about starting a program. So nothing had happened in Ethiopia at all on smallpox up until late 1970, before I managed to get into Ethiopia and lay out a plan, and by various devices, working through the emperor, get approval to get started in Ethiopia. So we came to the summer of '73. We had programs in all the countries, and we were very optimistic that now we're on our way. And the big problem, frankly, at that time was India. Huge country. A number of people talked about India being like the native, like we talk about cholera being the home, or India being the home of cholera. And there were some who said, well, India with a very dense population, particular climate and so forth, there must something special here. This maybe is the home for smallpox. Very difficult. You'll never get rid of it there. And that was the general discussion that was going on. And we weren't making much progress. India had started a program back in 1962, not so long after the first World Health Assembly had said, well, let's do an eradication program. By the time they got to 1973, they'd made progress in some of the southern states of India, but most of India, they were still recording as much smallpox as they'd had 11 years before. And they were discouraged and really not sure they would continue. There was a lot of discussion about it, and it was a problem saying we really have to keep going. And they agreed to do so, and this was in the earlier '70s. They agreed to keep on going. But then we met in sort of the late spring of '73, and we said, we've got to do something different.
And who's meeting?
In India. The strategy that we'd had was not working. They had done a lot of vaccinating. They were doing mass vaccination all the time. They were then beginning to do what we called surveillance and containment, really getting much better reporting. And when a report came from a village, they'd go out, send a team out, and try to vaccinate and control the outbreak. But it didn't seem to be working. There was still a lot of cases, and they were not making progress. So that spring, we decided what we needed to do was find the cases more quickly, find them before they became outbreaks. So the decision was made that we'd try to undertake a village-by-village search throughout the whole of India in 10 days' time. Mobilize the health services for an intensive 10-day search. And with this, we would employ about 120,000 people. And the idea initially was to go to selected parts of the village in a particular pattern to try and find cases and see what you could turn up. And there was a lot of planning, a lot of organization went on. We got Bill Fagey from CDC was sent over. I'd asked for more help. They sent over a couple of people, but India's a big place, and we had a crack team of international from France, from Czechoslovakia, from Soviet Union, but not a lot. We were very few. And so the first search was completed in October, and there's one state of India. We were normally getting about 500 cases a week. And that first search was completed, and they recorded 10,000 new cases found. 10,000 new cases. This wasn't even the high point in the season. This was really at almost the beginning of when the seasonal increase occurred. And I thought, oh my gosh, this is far, far worse than we'd ever imagined. Well, it was even worse than that, because it wasn't until several weeks later I found that the search teams had not done a great job, and they'd really reached only half of the villages. So it was probably twice as bad as I thought it was. They repeated the search in another 2 months, and they got better. By about the third search, it had gotten to the point where they would do house to house. And we actually had a team following and doing a sample number of the villages to make sure that they'd really reached at least 80% of the houses. And so we began gradually to mobilize this tremendous force. It took 8 tons of paper for one search. But we began getting more cases. The cases were increasing. The problems were that of mobilizing staff, of supervision, of quality control. It was a really tough job. And we went on in through the summer of since 1974, when at that time the smallpox goes down to its lowest point. Somehow smallpox transmits best like measles in the winter. Measles is a winter disease. Smallpox is the same. And whatever it is, whether it's being drier air and cooler air that does it, we don't really know all the answers, but certainly the summer months are where it gets to the lowest point. So the summers in the states, northern states where this almost all the smallpox was, the summers are terrible. 120 degrees. There's not a limited amount of electricity, and there's certainly no air conditioning. And we were bringing in a lot of people on 3-month volunteer stints to work with our Indian colleagues. And that summer, it was murder. And we brought them together once a month, looked at what they'd done, reports, reviewed all of these. We had no cell phones. We had no telephones. There was no computers. I mean, this was all done by hand. And they'd come in for a weekend, and we'd come in for work for a day, and then they had 1 day to rest.
Can you identify a turning point in the Indian experience?
Yeah, I'll come to that in a moment. There was a turning point, but a strange one. We worked through 74, but God, we started going into late 74. The seasonal picked up. There were more cases than ever. It was really going. And there were sort of longer-term trends in the disease in India, and this was consonant with a longer-term trend. It was on its way up, and we were not having that much of an effect. However, by the time we got to around February, we realized that the search system was in place, that we had some very good people supervising this. And in fact, I even remember the time it was with Bill Faggy. The two of us were looking at this and wondering now, where were we at this point in time? And but as Bill said, I'm not sure I'm going to put out a weekly, he's putting out, I guess, a bi-weekly report. And the curve was going up, and he said, the only thing I can do that's optimistic is turn it upside down. But we felt at that time, secretly, that we were on our way. And it got worse. And it got worse at a bad time in a way, and a good time in others. India detonated a nuclear device. They had press coming from all over. And the theme of all of the coverage, news coverage, was India detonates nuclear device, smallpox. Their health system is so bad that they are the world's primary country for smallpox. And so here's this advanced country with such primitive health facilities that it's epidemic for smallpox. This got a lot of interest. The Indian government was not pleased. They were very upset, and they began making more resources available. And higher levels in government began paying attention to it. And they assigned to the program, from the Indian side, 4 of their very best people to work with 4 of our central people. We called it the Central Appraisal Team. Well, we got over that, and for India at least, we came to the end of the last cases in May of 1975. We thought we had the last case. It was a beggar woman out on a railway platform in the far eastern part of India going into a whole area, and if she had infected a bunch of people going out there, we had no idea what was going on. But by that time, by October, the Minister of Health and the Prime Minister were very excited about this. And we were not confident that we'd gotten rid of smallpox. August 15th is India's Independence Day. And they were determined to announce that this was India's Independence Day and its freedom from smallpox for its first time in history. I would say we're chewing our fingernails at that time thinking, oh my gosh, if they have more cases, you know, the press coverage and these people don't know what they're doing. Oh God, really been awful. That was the last case. Meanwhile, Bangladesh was going through tragedy after tragedy of flood and famine, and we had an exhausted group really fighting to get rid of it in Bangladesh, which is a story unto itself. So on August 15th, the Director General and I headed for Bangladesh. They only had, I don't know, something like maybe 80 villages infected at that point. It was just really coming way down, and we felt, my gosh, I think we're going to be rid of this bad disease for all the world. It's a very severe type of smallpox. That would have been it. So we were on our way to the airport and got the word all flights are canceled. And the Prime Minister, or the President of the country, really the founding father of the country, Mujibur Rahman, had been assassinated along with his entire family. Martial law had been declared. Troops were moving to the border. Floods of refugees were expected. And we thought, oh my God, once more. But for some reason, the international group was laid low. They worked locally. They kept out of the way. And the expected civil war that was expected to erupt immediately did not. And they went back to work, and finally, in October of '75, was all done in Asia. And then we were left with Ethiopia and Somalia, subsequently Somalia. Well, if you'd like to hear the rest of the story, I can go on Ethiopia, but Ethiopia is a huge country. People look at the map and they say, oh, it's about the same size as Georgia. Not so. It's equivalent to all of the states on the eastern seaboard of the United States in area. It's huge. There are very few roads, all-weather roads, or even roads you can drive on. It's estimated, I think, that 2/3 of the population lives more than one day's walk from any accessible road, at least one day. And the government had only, I think, 2,000 health workers in the whole country. And for a while, we were working with 20 Ethiopian sanitarians, 14 U.S. Peace Corps, about 6 Japanese Peace Corps, and some Austrian Peace Corps. and some volunteers who kind of wandered in. Anybody who wanted to work, we put them to work and paid them the Ethiopian per diem, which you didn't live high on the hog on that one, I can tell you. Then, as they were making progress slowly, but it was difficult. And for the first time, we ran into a huge area where the people fought against vaccination. They didn't want it. And trying to solve that problem took us some doing, but finally they wanted malaria drugs. And we could give them malaria drugs. We got malaria drugs to give them, provided they got vaccinated first. And so they got vaccinated first and got the drugs. Not the way you like to run a program, but that was the only way we were going to stop the disease. It was a less severe disease than, let's say, in Asia. So there's less motivation, less concern on the part of government. Well, we get, all of a sudden, the Emperor Haile Selassie was in charge and had been there, you know, as emperor for a long time. And they had a coup, military coup. Marxist military group took over. And civil war broke out. So there was fighting in different parts of the country. The emperor was, I don't really know what happened to him. I think he was killed. And then it was the U.S. Peace Corps had to pull out, as did the other groups. A number of the embassy people pulled out. And for quite a period of time, the only people allowed by the military to go outside of Addis Ababa were the smallpox group. And we had some very good people, particularly our person who was a real leader of the program was a Brazilian fellow by the name of Sencer de Quadros. And he had a charm and an ability to persuade that was legendary. And that's why we had permission to go outside the country. But that wasn't much fun because they had to go to many of the provinces with military escort because it was too dangerous. So they fought through all of that. It was really horrendous. And then they came to a point, finally, we got additional people in, and then finally the Surgeon General of the United States came up with a contribution of $1 million for us to get 3 helicopters to transport people. It was so big. That made a huge difference. Well, one of them was shot down, one of them getting up there, I don't know, we don't know what reason, went into Lake Kenya. Another one was hit with, they threw a hand grenade at it, but we were able to repair those. And they took one for us, we had to get one of them a hostage. They were captured, and we had ransom notes, which I've still got a copy of the request for ransom from the people, dictated by the rebels, written by the helicopter pilot, who, while he was captured, took the vaccine and got all the rebels vaccinated, so took care of that. He was thinking all the time. But finally, we got to this place in Demo, a little village way down in the desert. The last case, I flew down. We thought we got a television crew down there, you know, film this, and we did, and got a lot of footage of Demo. Crazy little village sitting in the middle of a desert. We had a hard time even finding it with by helicopter. You couldn't spot it at a great distance. And we went back and we waited, and they searched. Nothing. Nothing. And it went on for 8 weeks, and we were about ready to make a statement to the press. We're done. And there was a report came in of 2 cases in Somalia right next door. Well, to make a long story short, the Somali government, even with all the discussions we'd had with them, had been hiding cases. They knew they had smallpox. They were admitting them to a hospital in a sort of secret ward nobody knew about. And they were trying to stop it, but because they were embarrassed, the only country with smallpox. They hated the Ethiopians, and they hated the thought that Ethiopia was free of smallpox. They refused to believe that they were free. And this went on, and as they would let our people come in, but they wouldn't let them go out beyond the main city of Mogadishu. And the cases kept occurring, but they were having trouble finding out where were they coming from. In other words, who was infecting them. And finally, there was a great discussion about this, and one of them, the turning points, I think there was a couple of turning points that happened. One being they captured a Dutch advisor who we had working with Ethiopians. And he was kidnapped, if you will, with his team and vehicle and taken to Mogadishu. I think we had 8 or 9 of these. And then the UN commissioner would intervene and talk to the president and the minister. And this fellow, Bertrand van Ramshorst, finally they took him, he asked to see the minister. And so he sat down with the minister and pretty well persuaded him that Ethiopia was free of smallpox and that there was a problem and that the WHO would be willing to help and so forth and so on. He made quite a persuasive pitch here. Meanwhile, the Assistant Director General, Ivan Ladny, indicated he wanted to come down and visit the city of Mogadishu, to the capital, and to meet with the minister. And the Director General was threatening to do the same, and I think the pressure was on. And then they began to loosen up. And so from then until this was about March of '77, and the number of cases, as I recall, are about 3,000 cases finally, that they had, troubles because they had nomad groups moving all over the desert area, couldn't find them, smallpox kept spreading, and you couldn't vaccinate them. It wasn't, they didn't resist vaccination, you just couldn't find them. And then the great problem was, come November, was the Hajj. And Somalia is right near, not near Saudi Arabia. Many people come from Somalia to Mecca. And all we could imagine were people, and they would come through Somalia from other countries, all we could imagine was, can we possibly have, at this time, one of these groups infected going into Mecca and spreading it among hundreds of thousands of people and watching smallpox go like this. So there was a frantic effort in terms of, they flew in vehicles so that we had more mobility. They flew in all sorts of people, and the government declared a national emergency, and it went all out. And on October 26, 1977, the Ali Mal Malan, a cook, 23-year-old cook, was the last case of smallpox. And that was the end of the smallpox. We had to spend 2 more years working in the countries to make sure it was really the last one.
How did you find out about that last case? Do you remember?
Oh, yeah. They'd brought in some people. At this point in time, they were moving people to an isolation camp to make sure that they'd be held. And there was 2 kids who were brought in by a vehicle from outside, one of the program vehicles. And they brought them in, and they stopped at the hospital to inquire about where the camp was. Now, Ali Milan was a cook at the hospital. He's supposed to have been vaccinated, but he wasn't. He'd been a vaccinator, in fact, but he hadn't been vaccinated. Everything went wrong. He got in the vehicle, rode for about 10 minutes till they got to the isolation camp. He got out, and he came down with smallpox. Well, he came down with a rash. And as often the case, the last is the worst. He was admitted to the hospital and diagnosed as chickenpox. And finally, they actually discharged him with a mild case of chickenpox. And it was one of the other people, friends of his, who said, "I don't think this is chickenpox." It wasn't. Smallpox. And he was a very popular guy, and he had contact with all sorts of people. So there were everything from roadblocks to all-night searches throughout Mogadishu to goodness knows what, trying to find possible other cases. But it was the last.
So do you have any final thoughts, anything you want to share about your experience over the course of the years in the program?
Well, I think there were several things about the program that were very special. And that is that we came together, people from across the world worked together very well. I worked very closely with the Russians. It was during the darkest days of the Cold War. Totally cooperative. We shared all sorts of problems, and they had some things that needed to be corrected, and I flew to Moscow. We talked it over. They corrected them. We had people working across borders from one country to another. We had mix of nationalities out there. What was perfectly clear was that if we had a goal, we had leadership at all these levels, that it became a very unique situation. Bridges were built such as you can't imagine. It was formed the basis for going on from smallpox, when we really convened a meeting and before the program is over to say, the vaccination has been so inexpensive, we can vaccinate so many people in a day, so effectively, so efficiently, we should be doing more than smallpox vaccine. And this was an international meeting we held, and from that came recommendations for an expanded program on immunization, which was finally accepted by the World Health Assembly in 1974, even before the end of smallpox. And the idea was to add other vaccines: diphtheria, whooping cough, tetanus, the DPT vaccine, measles, and polio, and add this to smallpox. And that was adopted, and then UNICEF got behind it, and Rotary got behind the polio side, and the goal was at that time to reach 80% of the world's children by 1990 with these 6 vaccines. And at the beginning, we estimated that at best about 10% were receiving these vaccines. So you had cases of tetanus, diphtheria, totally preventable diseases, whole wards full of whooping cough and so forth, and good vaccines out there. Well, made it. So by 1990, 80% of the world's children had been vaccinated against these 6 diseases. So this was the expanded program in immunization, which has gone on, became in due course the eradication of polio. It served to eradicate measles throughout the Western Hemisphere. Measles was gone. We had so few cases of tetanus and diphtheria that it was amazing. They were exceptionally just throughout the whole of the Americas. They developed a reporting system, which I think at the beginning we had 500 hospitals reporting once a month. The last count I looked at, their reporting, they have weekly reporting from 42,000 sites in Latin America. People just, it's better reporting for these diseases than it is in the United States of America. And this has gone on to develop the group that has convened here have done all sorts of marvelous things. And out of this came a feeling of, we've done this, why can't we take on something else? They've done that with great success. So there is a real need for an international organization, WHO, even though there's some of those like our President Bush who have not felt the need to work with other countries. This could never have been done in the United States. It could never have done by a few countries. It had to have an international organization. It showed also how much you can do with preventive medicine and public health, vaccines. We were dealing with 10 to 15 million cases of smallpox a year, 2 million deaths a year. And 10 years later, we have 0 cases and 0 deaths. This is pretty dramatic. And now you're seeing similar things happening with measles. Very dramatic changes. And now we're talking about, with the Gates Foundation supporting a lot of things, why can't we go and tackle malaria in a different way? Why aren't we doing research to get better vaccine for tuberculosis? Why don't we have a vaccine against malaria? It's opened up, it's begun a whole revolution in prevention, which is really something to see. And today, or the last couple of days, we've been hearing reports of now how many different fronts it's moving on very rapidly, and really rethinking all of this. It has, I think, built bridges in the international field that you can't build in agriculture or education. Those are political. Agriculture, for obvious reasons. Even education becomes quite political. With the health side, you really just don't get into political issues. It's amazing you don't. And so thus it has built relationships in ways that are really quite unique across the Americas, which I've spent more time with of recent date, but in other areas as well. They had days of tranquility in the Americas, where in the fighting in Nicaragua, the agreement was they'd stop fighting for 2 days. And they would, and the vaccination teams would go out. This has happened in Afghanistan, days of tranquility. So that even the rebel groups could be approached and could be helpful. So we got to Peru and the end of polio in the Americas. The last cases were in the area called the Shining Path, where the Shining Path was. They destroyed hospitals, they destroyed schools, what have you. And what they, people really, behind the scenes, Ciro de Quadros, who was the head of immunization for the Americas, had met with the commanders of the Shining Path and talked it through and got commitments for them not to harm the health workers while they went through, and this is what the health workers are doing. Guess what? They searched this whole area, which was so dangerous, it was a problem for the military to go into. So there is, it's something that I think is unique about health here, and something which gives you great encouragement for the future. And thus I really feel quite, I feel like we've made a difference well beyond smallpox eradication. I think, well, smallpox eradication, I think, has been a first step. And we're now moving on well beyond that into many more exciting things.
Great. D.A. Henderson, thank you very much for speaking.
Yeah, you're very welcome.